Hello and welcome to the Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies.
Well, hello, Mike, and I'm Martha Roberts. I'm an emergency medicine NP and assistant professor in Northern California.
Well, it is the saddest time of the year around Sharma Studios. This is a little inside baseball, but when my oldest daughter, Geeka, is home from college, she sleeps here. This is a spare bedroom, and her bed is right over there. That's where she sleeps. And we have to kind of work around each other during the summers. But I took her to college a week or two ago, and she's back there now. And so we're back to a studio of just one right now, and it's really sad. Just got back, though, from celebrating the first day of school, traditional froyo celebration for the family, celebrating when they have the first day of school. And my wife, Monty, is also back teaching for the first time in a long time in the classroom. So we are a little family of teachers here these days.
Wow, that's a lot going on. Well, ice cream's been hot over here, too, because it is hot in California, over 100 today, and we've had some heat advisories all week long. But when it's hot like this, I can't sleep. I don't know what you all do when it's really hot, because sometimes we don't turn the air conditioner on. I mean, we try to get it cool throughout the day and kind of turn it off around 6 p.m., you know, because that's when the rates go up real high. But recently it's been a little too hot. So I got an itch to learn about a cool drug that does a few things and has been doing a few things for a few days for me. I'm going to call it a multitasking drug, and that's Remeron. And I want to stay on trend, you know. Mike, would you consider hearing about an old drug before we jump into new things like 2 60-second snippets instead of one, like a 2-4?
Yeah, I'm sure no one would mind.
Yeah. I mean, look, I don't know what you all do when you can't sleep, but everyone knows that I have insomnia. I worked night shift for over a decade, and I still was working a few night shifts, which, by the way, took years off my life. I wish that we didn't have to do that as healthcare providers. And I certainly prefer the shift. I don't know about you, Mike, by the way. What do you prefer? Do you prefer night shift?
Day all day, baby. I love day shifts. Yeah.
Okay. I just don't like the attitudes. But I wanted to bring up Remeron on the show, otherwise known as mirtazapine, because I want to take it to the next level here, where maybe we've been working with some medicines over the years or some treatments or some things that we've done, and we kind of want to branch out. And I think as a podcast family, we should be branching out. So mirtazapine is an antidepressant. It balances neurotransmitters in the brain. It's sort of like SSRIs, but not. So basically, they can do the same things for people for anxiety, depression, insomnia, a slew of other things. But Remeron's really unique. And I'm giving it a little applause. You hear that? A little applause?
I hear a little, yeah.
Yeah, just a little bit. Because it works on a really unique mechanism, which helps either promote sleep or give you more energy. Now, I just want to briefly explain that because it is blocking central alpha-2 adrenergic receptors, which increases the release of both serotonin and norepinephrine. But when you give mirtazapine at small doses, 3.5 or 7 milligrams, 7.5 milligrams in that range, mirtazapine primarily affects the histamine H1 receptors, resulting in significant, and I'm talking significant sedation. And this action can lead to anti-anxiety, anti-agitation. I mean, we know how agitated I get. So it's also a really strong 5-HT3 receptor antagonist, which can help with nausea and vomiting. And at higher quantities, we're talking like 20 and 30 milligrams, which is super high. It can actually help with depression, PTSD, all these other things. So what a crazy drug. At very, very low levels, it puts you to sleep. At very, very high levels, it kind of turns you on and wakes you up. I mean, it's really crazy. The best thing about this is that, in my opinion, it has very, very few side effects related to QTC prolongation, Mike, which hydroxyzine and trazodone can cause. So, I mean...
Okay. Ask your PA or NP if mirtazapine is right for you, I suppose. But yes, it's great. You know, they say they can't teach an old dog new tricks, but it doesn't go over drugs. I guess you can teach some drugs some new tricks, perhaps, if you use them differently.
Yeah. Well, new uses for old drugs, and old drugs making a comeback, like penny loafers and Mary Janes for this fall season.
Well, it's time for our first segment, the wet read, where Martha and I get 60 quick seconds to talk about something that caught our eye.
All right, so technically this is my twofer, but you found this one for me this month. Love it. Pediatric nicotine pouch ingestions. So we got a sweet spot for toxicology here on the two view, and let's talk nicotine ingestions in pediatric patients. A recent study in Pediatrics, the journal Pediatrics, suggests a spike in nicotine ingestions in children over recent years. I have a reason for this, Mike, by the way. The study looked at unintentional nicotine ingestions reported to the National Poison Data System in 2010 to 2023, and that includes various forms of nicotine like gum, e-liquids, cigarettes, pouches, and others. Anything that gives you that fix. So highlights from this data: of the over 134,000 ingestions, only 2 led to fatalities, which my research couldn't figure out what those were, and those involved the e-liquids. However, the most likely form to be associated with serious outcomes or admission is nicotine pouches, with a 1.5 to 2 times increased likelihood of these bad outcomes as compared to other forms. Further, there was and this is not a misprint, 760% increased rate of ingestion of these pouches between the following years, 2020 and 2023. I'm going to talk about that in a second. Effects of nicotine toxicity can cause a variety of symptoms ranging from nausea, vomiting, hypertension, tachycardia, seizures, respiratory failure, coma, and death. And Mike, I know why this was.
Okay.
So COVID put all the kids at home, and COVID made all the stressed out parents go back to smoking. I'm telling you, the stress from that time, I know so many people that quit smoking for years and either got back on the gum or e-cigarettes, vaping. There are all these crazy marketing things for these items that really make people want to buy them. And further, I just want to add, the link that you sent me, did you know that it contains a 4 to 5 minute video Snapchat of the citation by a professional toxicologist? And they do that for all their journal articles now. Did you know that?
Oh, it's in pediatrics they do that?
Yeah.
That's really cool. I like that a lot.
So in 5 minutes, I heard the whole study. I still read the study. Great study, by the way. I mean, really good. But anyway, the point is, note the Poison Control Center loves to hear about these cases. So go ahead and check them out for more, or sign up for the Poison Post email. And then it's like, you're in it to win it.
There is no specific antidote for nicotine poisoning. Prevention and supportive care win the day here. Consider activated charcoal, of course, if the patient presents shortly after ingestion. Typical medications and adjuncts to treat hypertension, seizure, and respiratory failure are all in play. Let's switch gears from poppin' zins to poppin' pneumothoraces. The journal Current Problems in Surgery, much better than Old Problems in Surgery, frankly. I really prefer Current Problems in Surgery. Published an article entitled Management of Traumatic Pneumothorax and Hemothorax in February 2025. There is a ton of interesting information here, but I want to focus in on one of the big killers when it comes to chest trauma, the tension pneumothorax. As you know, a tension pneumo is when there is so much air in the chest, in the pleural space, that the patient is now going into shock. They're hypotensive, they're altered, and they're about to freaking die on you if you don't do something. So what do? The answer for a long time has been a needle decompression, also known as a needle thoracostomy. Current guidelines suggest this should be done at the 5th intercostal space along the anterior axillary line near the armpit. This gets around any adiposity or large pec muscles or other meat and cheese that might be in the way, but still has a failure rates as high as 10 to 15%. Not great when you're dealing with a true killer. This article suggests that a different procedure, a finger thoracostomy, should be the procedure of choice for a tension pneumo instead of a needle decompression, even going so far as to say that a needle decompression should only be considered if there's a delay in obtaining supplies for a finger thoracostomy or chest tube. Pretty strong words.
So I've been doing this. I haven't done one lately, but I have done this. And I've been doing it for a long time. My father taught me how to do this. And you know how he taught me how to do it was we used premature unripe oranges. And you really had to shove your finger in there. And it really trained you of how much torque to put on that finger. Unripe oranges. Just saying, don't use a banana because that ain't legit. But giving your patients the finger, so to speak, has been a controversial topic, we know. But it's really gaining traction. especially with articles like this. There's more about this procedure at Scott Weingart's MCRIT website, too. In addition, the Journal of Trauma and Acute Care Surgery just published a review article on traumatic pneumothorax and hemothorax in July of 2025.
Friend of the podcast, PA Chip Lang, also mentions this procedure, the finger thoracostomy, in the ATLS review episode that he and I did on chest trauma for ATLS 10th edition. Guess what? There's a new sheriff in town. ATLS 11th edition dropped in July 2025. That is yet to percolate out to everybody. I just recertified ATLS this month, actually, and it was still a 10th edition. So I'm so curious to dig into the 11th and see what they're changing. They're making some really big changes. I want to cover that on a future 2 view, I believe, once I kind of go through the manual in detail. Links for all of those sites, all the articles, all the podcasts, all the topics we cover are going to be in the show notes. As always, they're at 2view.fireside.fm. That's the number 2view.fireside.fm.
All right, so while we're getting excited here, get excited even further for our next boot camp, which is November 4th through 8th at Planet Hollywood in Las Vegas. We also have some pre-workshops before. You know the drill. Go to the website, www.ccme.org, and check it out. I also highly suggest that you look at our airway course. Take a look at it. It's really good, and I think you'll like it. So that's the plug this month.
I want to drop a different plug. There is another conference that we are hosting at the ccme.org website called Incrementum. And Incrementum was a really big conference done in Spain this year, and it really gives as the kids say, it's giving smack dub energy, or it's giving essentials energy. Just the way it looks really fun and interesting, and I'm so curious to watch this course. Even though was done in Spain, the presentations are entirely in English. It looks really compelling. A lot of the people you've come to know and love from the CCME orbit are on stage, to include our buddy Dr. Ken Milne and others. So consider it Incrementum. It's on the www.ccme.org website, which is where, again, you can register for our November boot camp. Of course, you can get the advanced boot camp. You can get anything you want at www.ccme.org.
Yeah, Ken was telling me about that. Sarah Krager did a lot of the talks there, and so did Jess Mason. Scott Weingart was there. Just a lot of really great people. It's so cool to see them doing all this fun stuff. So, yeah, check that out. Good plug. I forgot about that one. All right, let's move on to segment 2. That's the dry scan, where we penetrate a little deeper into 2 other topics. And this month, we're talking about hepatitis C screening in the emergency department. And yes, we've had this all happen to us. And if it hasn't happened to you yet, it will. You order a comprehensive metabolic panel and liver function tests like AST, ALT, and they're slightly elevated. Not so much that it's an emergency, but like, what's going on here? Is the person having transaminitis, as they say, from an unrelated infection like influenza, or COVID-19 or the adenovirus? Is it just a random elevation that's idiopathic and it's going to go away in a few weeks? Or might perhaps this patient have viral hepatitis? On the different viral hepatitis infections, mostly agree, I think we would agree, that hepatitis C is the most concerning. It is the hepatitis virus that is the most associated with conversation from acute to chronic hepatitis infection, can lead to cirrhosis, liver cancer, as if cirrhosis wasn't bad enough. And the Journal of the American Medical Association, JAMA, as we know it, published the study in July 2025 called Detect Hep-C, randomized clinical trial. The purpose of the study was to determine the most effective way to screen patients for hepatitis C in the ED. This was a multi-center prospective randomized trial, I like it already, of adults with no critical illnesses or previously diagnosed HCV, performed at 3 urban EDs in the United States. Over 147,000 patient visits were randomized into 2 different but roughly equalized size groups. In one group, they had the targeted screening group. Only patients who were at high risk for hepatitis C were offered the screening. In another group, the non-targeted screening group, all patients were offered the screening. In the end, 115 patients in the targeted screening group tested positive for Hep-C, while a larger number in the non-targeted screening group, 154 patients, tested positive for active hepatitis C infection. And the author suggested that this was a statistically significant increase in identifying infection. So consider running a hepatitis panel on your next patient with elevated LFTs, even if they don't seem to be at high risk for hepatitis C.
That's a lot of hepatitis. What is troubling is the next part of the study, which showed a major drop off in the amount of patients who were linked to follow-on care, got treatment, and finally attained sustained viral response to treatment. That last number was less than 10% in each group of people who got diagnosed with an active infection. So only 1 in 10 of those people were going on to get that virus cleared. If you're going to be testing more, if you choose to listen to the study and go, maybe I should be screening more for Hep-C in the ER, it's really important you know how your local resources and about how people can get the next step treatment. I talk about it a lot, but I'm just so blessed to work where I work, where there are a lot of resources for people who don't otherwise have a lot of means. And if I find hepatitis C in somebody, I can really connect them to that care. So consider, I don't know about you, Martha, but like we screen a lot for HIV in our ER. Like basically, unless you tell us, no, don't test me, and you haven't had a test in a while, if we're drawing blood, we're probably testing you for HIV as well. And so I'm just so curious if we need to be starting to add Hep C to the mix there because of how problematic it can be in the long term.
Yeah, we actually look for syphilis in every pregnant patient that comes in. If they're getting blood tests, or we offer it if we're not obtaining blood tests. So that is something that we do in the city.
So much sneaky stuff out there, especially that's syphilis. We've talked about that in previous episodes, even the last one, episode 48, I believe, we talked about ocular syphilis, so look back on that if you like to, no pun intended. Well, I'm going to talk about a different test for a different organ. If you have access to high sensitivity or HS troponins in your ED, you're probably used to some sort of protocol in which you're evaluating patients for myocardial infarction by drawing one time or like serial, back to back to back over certain time gates, HS troponin levels. Even with slightly elevated troponin levels, certain protocols indicate that this rules out myocardial infarction. Like if you haven't hit a certain number by a certain time after the onset of chest pain, you're good to go even though it is high. A retrospective observational study in the American Journal of EM suggests that 2 troponins may yield additional interesting information. The authors observed over 4,000 patients who got at least 2 HS troponins drawn. Of the first group, containing patients with a change in their troponin, or as we say, the delta T, the delta troponin, of 15 nanograms or less, only 3.6% of them had a major adverse cardiac event, or MACE, in 30 days. So in that delta troponin group, less than 15 or equal to 15 changes between the two, less than 4% in 30 days. That's pretty solid. However, in the 2 other groups that has a rise or fall of HS tropes over greater than 15 nanograms per liter, 34.4% and 14.5% of them, respectively, had a MACE in the 30 days after that hospital encounter.
So after some adjustments for confounding factors, the adjusted odds ratio for 30-day MACE for the rising troponins group was 7.68. The adjusted odds ratio for 30-day MACE for falling troponins group was also positive at 1.99.
Yeah, even if they technically, rule out, as they say, for MI, it's worth considering whether these rising or falling troponin patients would benefit from an expedited additional risk stratification with something like a coronary CT angiogram, if you have access to that through your ED, or maybe like an observation unit or even an admission, depending on your patient's ability to follow up with a cardiologist after their ED visit. The less likely they are able to to follow up, the more aggressively you want to think about bringing him into the hospital. And to that point, Martha, we both work in busy county EDs. I don't know about you, but I'm often in the position of meeting people very early in their ED stay with the chief complaint of chest pain. Like if I'm thinking about doing an MI workup, even though I know, like let's say they come in, they're like, I've been having chest pain for like 12 hours in a row. Okay, well, like based on a lot of our, flow charts, I might be able to technically rule out an MI with just one troponin based on that story. But if these patients are going to be kicking it in my ED waiting room for like 3, 6, 9, 12 hours, I've personally just decided to order serial troponins on these patients. One gets you two in my book. These patients are moving targets. The second that I finish my little initial screening evaluation, who knows what happens when they go to the waiting room if their chest pain starts evolving. I don't want the person who picks up this patient on the back end to be stuck with just my one troponin if their story changes in the waiting room. What do you think about that? Do you do any sort of screening? Who is doing screening over there in San Francisco? And what are the thought processes there for doing HS tropes early on in their stay? What do you think?
Yeah, we do that. And we do have clinicians in triage of all sorts, shapes, and sizes.
Mm-hmm.
And this is a big part of what we do at the county hospital because, believe it or not, we can send some of these patients home, even with troponins. Obviously, if we can get that done in the beginning stages of their visit, I'll discharge them.
Yeah. Okay. Cool. Well, lastly, it's our oral contrast segment where we get into all the nooks and crannies of a topic. We've got a big guideline released by the Infectious Disease Society of America, or IDSA, on a very common problem we deal with in emergency medicine and urgent care, the complicated UTI. The last guidelines in general on UTIs were released by IDSA in 2010. I like to say when a textbook or guideline is old enough to get a learner's permit, it's well past time to make sure the science hasn't advanced after the publication of said textbook or said guideline. I'd be thinking, hey, you guys just covered UTIs in episode 46. Well, that was a very specific study regarding the efficacy of cephalosporins in pyelonephritis patients going home. This is a much broader ranging guideline that covers, again, the complicated UTI in general and includes many more conditions that were excluded in that previous study.
Mike, I just want to say that occasionally I drop these articles or really long guideline packets into ChatGPT or some other Perplexity or something AI,
Right.
just because I found that it does a pretty good job of summarizing. I still read these. I read it all, and then I was like, this is a good time for me to pop this in to something AI and just see if it came to the same conclusions I did. But I just want to let you know I programmed my AI to have a specific personality. And so basically just quick, I just wanted to tell you some of the things that it said. It said, don't go wild, tailor empiric therapy. And then culture results, time to de-escalate. So there's all these really cool things that it does. But anyway, before we go much further there, or I go too far down a rabbit hole, let's further define complicated UTI. Let's just do it, IDSA or IDSA, whatever you want to say.
I call it, do people not call it IDSA? Is that just me? Am I on an island here?
I don't know.
I'm on IDSA Island.
We talked about this last time, and I don't think we came to an agreement. I can ask ChatGPT. But IDSA has made things a little, less complicated with its new definitions. Okay. Previously, complicated UTI was kind of like a category of leftovers. You had uncomplicated UTIs and acute pyelonephritis, and then everything else was a complicated UTI. And in 2025, IDSA is making it easier. UTI is either uncomplicated or complicated. That's it. Their definition of uncomplicated UTI is an infection confined to the bladder in an afebrile man or woman. This is already a huge change. Previously, being a man and having a UTI would immediately land you in the complicated UTI category. Go figure, dudes. That's no longer the case.
Yeah, when you get a guy involved, automatically things get more complicated. Well, just kidding. Okay, uncomplicated UTI, an infection confined to the bladder in an afebrile woman or man. File that, park that for later. So, what's a complicated UTI? According to IDSA, this is a UTI with an infection suspected to be beyond the bladder. Pretty straightforward. Why might we suspect that somebody is having UTI beyond their bladder? A couple of example symptoms are listed, like fever, other signs and symptoms of systemic illness. This could include things like chills, right? Do you say rigors or rigors?
Rigors.
Right, it's rigors. Okay. All right, we're on the same page there. Or hemodynamic instability, flank pain, costovertebral angle tenderness. So this category includes, as you could figure, pyelo. Maybe it includes also, it does include actually, febrile or bacteremic UTI, catheter-associated UTI. How do you say that? Do you say CAUTI or do you see CAUTI? How do you say that?
Quaddy.
Do you say quaddy, really?
Quaddy, because
Okay.
I'm from Philadelphia.
Okay, Caudy because you're naughty? Is that why? Anyways.
Oh, God, Lord.
And prostatitis. Now, all you prostate fans out there will probably be slightly disappointed that acute bacterial prostatitis is not covered by these guidelines. So if you got a patient with ABP, then you can't use these guidelines to deal with that.
Okay, I had to make a few notes about my new band name. So I'm going to decide between Beyond the Bladder, BTB,
BTB.
Finger in the Orange,
Oh.
or FIO, or Quaddy. Those are my 3 band names. Emergency medicine, yes, is often at the tip of the spear in diagnosing these complicated UTIs. And thankfully, we have a seat at the table for these guidelines. And with the Society of Academic Emergency Medicine being one of the organizations that reviewed and provided feedback on the guidelines, that is great. Often we are treating complicated UTI. We are having to pick an antibiotic without having the results of a culture or sensitivity report to confirm the presence of bacteria and resistance pattern. And we're making an empiric choice, right? We have these great empiric choices early because these patients are complicated and potentially sicker with the UTI than just having a questionable bladder infection. And those less sick, especially if they are young and healthy, can often wait a few days. And if we're not quite sure if they have an infection or not. And that's the first but big clinical question that this guideline addresses. What should we initially choose for empiric treatment of the patient with a complicated UTI? So don't go wild, but maybe we should.
These guidelines make a big deal about this 4-step assessment that they have derived. When you've got a patient with a complicated UTI and using the results of this assessment to make this important choice, this important first choice for antibiotics, here's that assessment. Step 1, how sick is your patient? Step 2, are there resistant factors to consider? Step 3, are there any patient-specific considerations? And step 4, what does the local antibiogram have to say? Let's wrap back around to step 1. How sick is the patient? If the patient has sepsis due to their complicated UTI, the guidelines recommend initially selecting from among the following antibiotics: 3rd or 4th generation cephalosporins, piperacillin tazobactam, also known as Zosyn if you're nasty, the fluoroquinolones, that specifically ciprofloxacin and levofloxacin. They don't use Oflox or Moxiflox, interestingly, or carbapenems. They prefer these over newer agents or older aminoglycosides like gentamicin, amikacin, and tobramycin.
Mike, what about when your patient has a complicated UTI without sepsis? Then the guideline authors recommend roughly the same list with one change. Okay, they still recommend 3rd or 4th generation cephalosporins, piptaz or fluoroquinolones, or ciprofloxacin and levofloxacin. However, the authors do not recommend the use of carbapenems here. Okay, so ceftriaxone fans, this is a 3rd generation cephalosporin. So if this is your general preference, as it is mine, ceftriaxone is still one of the recommended antibiotics, even if your patient has sepsis. Other common 3rd generation cephlos are ceftonir, cefpodoxime, and cefexine or Suprex.
You call them cephlos? Is that what we're doing here?
Cephlos.
Is that a new thing you figured out today, or is that what you usually call them?
Band name,
The
Cephlos.
Cephlos. Okay.
I'm on it.
The mighty Cephlos.
You know what? I might spell it like, I might really truly spell it CEFPHLO instead of,
OW?
I don't
Would you add
know,
a W?
flows.
Okay,
Flow?
we'll workshop it.
Okay.
I think it's important to highlight the drugs that they don't recommend to be used as a first empiric choice for complicated UTI. They don't recommend trimethoprim sulfamethoxazole or TMP-SMX. They don't recommend amoxicillin clavulanate. Nitrofurantoin, fosfomycin, out. These work great for bladder infections, but they don't have the penetration and concentration in the blood or other organs like the kidneys that are needed when you have a complicated UTI. And the authors don't recommend first or second generation cephalosporin antibiotics. This includes things like cephalexin or Keflex. This includes cefuroxime or Ceftin. This is really interesting because I think a lot of us prescribe those antibiotics for patients with complicated UTI. In fact, in that cephalosporins and pyelo trial that we talked about a few podcasts ago, cephalexin was the most commonly used oral antibiotic, and it seemed to work okay in that trial. The authors do admit that their guidance suggesting third and fourth generation cephalosporins, yes, first and second, no, is based on very low certainty of evidence. So there's that.
All right, so let's consider step 2 of the 4-step process, resistance factors. Lots of these patients have had urine cultures before. These recommendations are, again, with very low certainty of evidence, but the authors recommend avoiding antibiotics that previous pathogens were resistant to and prioritizing more recent urine cultures over older urine cultures. And step 3 is pretty straightforward. Consider patient-specific considerations in choosing an antibiotic. Obviously, are there allergies? Are there drug-drug interactions? I think we forget about that sometimes. Other contraindications. We've talked about them before in episode 34, but those fluoroquinolones have such interesting and potentially devastating side effects. I think they're worth considering whether the juice is worth the squeeze.
You've heard that expression before, right?
Yeah, I don't like it. That's why I said it that way.
Oh, I like it a lot. I mean, you're the one that brought up oranges. Anyways.
I mean, it's cool. Keep going.
Moving on to step 4, what does the antibiogram say? The guideline authors suggest that in patients with sepsis assumed to be caused by a UTI, consult an antibiogram if you can get one that is local, recent, and relevant. Local, derived from the same healthcare facility, which is tricky if you're in urgent care, right? I mean, like you don't really have an antibiogram in the urgent care. But anyways, recent, from the past 12 months, and relevant if it's considering organisms from similar patient populations, right? If your patient is in septic shock, the authors suggest picking an antibiotic for which the relevant pathogen has had 90% susceptibility or greater. If the patient is not in shock, the author suggests it's okay to pick an antibiotic for which the relevant pathogen has 80% susceptibility or greater. These recommendations for patients in shock are, again, based on very low certainty of evidence. They make no recommendations about consulting the antibiogram if the patient is not in shock.
So there are more recommendations in these guidelines about switching patients from broad-spectrum antibiotics to more targeted antibiotics and when to switch a patient from IV to oral antibiotics. And this may be more helpful in those of you who are in observation units or taking care of hospitalized patients. What is more applicable here is that most of you listening, the recommendations on the duration of the antibiotic prescription, broadly speaking, even though the duration is often based on clinicians wanting to make sure our patients are cured. I mean, but a lot of the studies suggest that patients are often prescribed antibiotics for longer than existing guidelines recommend, and that can lead to increased patient harm. This is a rock and a hard place that we find ourselves.
In patients with complicated UTI and improving clinically and effective therapy, the authors suggest treating with a shorter course of antibiotics than previously recommended. We're all used to picking 10-day, 14-day courses. This author group suggests 5 to 7 days if using a fluoroquinolone, or 7 days if using a non-fluoroquinolone antibiotic for a complicated UTI. That's really different from what we're used to for pyelo. We're used to saying 10 to 14 days for pyelo, 7 or less for a bladder infection. The authors describe moderate evidence backing the fluoroquinolone recommendation, but only very low certainty of evidence backing the non-fluoroquinolone recommendation of only going 7 days. Even in patients with complicated UTI and associated gram-negative bacteria, the authors suggest only treating for 7 days instead of a 14-day course if the patient is improving clinically on effective therapy.
I think this is a good time to talk about what we do when newly recent guidelines conflict with how we do things currently, especially when some of the guideline recommendations are based on low or very low quality evidence. And everyone in your ED or urgent care probably prescribes 10 to 14 days of antibiotics for a complicated UTI right now. If you're a PA or an NP, I don't think this is the time for you to be the first one to make this change. So talk about these changes with your attendings, collaborating physicians, see what they think, and then make a decision together about whether you're going to follow these guidelines in terms of duration of antibiotic prescribing or hold off a bit.
Yeah, I usually advise PAs and NPs against being the first to adopt the change or the last to adopt the change. You want to be somewhere in the middle. Where we can best use this aspect of the guidelines for now, in my opinion, is, we've had this before, right? Someone comes in, maybe they're bouncing back to the ED, or you happen to see them in urgent care or whatever, and they're 7 days into the antibiotic course. Maybe they're there in the ER because they're there for something else. They busted their knee or something, and they're like, I'm feeling great. I'm 7 days in on my antibiotics, and do I really have to go to 10 days or 14 days? I think this is a good time to have this shared decision-making discussion about how it might be okay to stop. Like the patient's already feeling better. It's been 7 days. They want to stop. I think you have that discussion with them. Say, hey, there's some recent guidelines suggesting you can stop. However, you were prescribed a 10 to 14-day course. I'm not really one to kind of like mess with someone else's prescription mindset. But it's something to consider. I'm not saying you have to continue. I'm not saying you must stop. There are pros and cons in both directions. And you choose, patient, what you think you value more. To recap these guidelines, when empirically treating complicated UTI, consider picking third or fourth generation cephalosporins, fluoroquinolones like Cipro or levofloxacin, or piperacillin tazobactam. If your patient is septic, carbapenems are another antibiotic choice you can consider in addition to those other ones I just mentioned. Further, consider recent urine cultures, patient considerations, and an antibiogram if it is local, recent, and relevant in your choice. And maybe 7 days of therapy is enough, even 5 to 7 days if we're using fluoroquinolones. But our personal suggestion there is to make that decision in coordination with collaborating physicians or medical directors.
Nice. So as a friend of the podcast, Ken Milne says, these aren't guidelines, they're guidelines. Let me say that again. They aren't guidelines. They are guidelines.
Nailed it.
And we're not mandated, to follow them just because they exist, especially if you have good reasoning or there's conflicting studies or, there's another recommendation, very low quality evidence, or you've, been hearing about many of these other recommendations today. And these recommendations are just part of a larger body of evidence about UTIs. So be on the lookout below about any changes recommended by your practice setting, and remember that you heard about them first on the two of you. And by the way, I don't know if you saw me this entire time, like messing with my head. I have a ponytail headache. Do you know what that is, Mike?
I have yet to have one of these because I have never had hair that long.
Mm-hmm. So there's a study back in Headache in 2004 that looked at women, females, just 93 females that were experiencing headaches from ponytails. And it's a legit thing. Certainly males can have similar experiences, but they weren't questioned in this study. And literally, these cause tension headaches. And so I think these are really interesting studies. In fact, there was another study in 2024. There are other topics on things like non-reputable sources like Facebook and Instagram, but the ponytail headache exists and I have one.
I believe you.
So empathetic. Let's talk about the trivia question. Here's our two-part trivia question. In the 1990s.
Close.
And I'm sorry. Gosh, I really wishful thinking here. In the
Nope.
In the 1890s.
Nailed it.
Wow. An oil painting entitled Inheritance depicted a woman with a child that had signs of neonatal syphilis. Who painted this? And what painting is that artist best known for? Anyway.
Why don't you read that one? Yeah, you read the answer.
You want me to?
It's if you don't want to, I'll read it.
You read it.
Edvard Munch and the Scream. The winner is P.A. David Michelson. This is really impressive. He answered the trivia question like an hour after the episode dropped. He was up, apparently, he must have been on shift because he was like, it was really early in the morning. So really amazing stuff, David. You got to get up early in the morning to get ahead of you in line, and we'll send you an email about what you win here. The two-part trivia question for this episode. Again, you can find everything we talk about on our website, 2view.fireside.fm. The two-part trivia question is this. Hepatitis has to do with an inflammation of the liver. What language does the name hepatitis have its roots in? And where in 2005 was hepatitis C finally discovered, so to speak? So where are the roots, the origins of the word hepatitis, and in what country did the Hep-C discovery take place in 2005? Email us your two-part answer in addition to anyone you'd like to give a shout out to, as well as any feedback or comments about any episode, Martha's band names, or our format to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. By the way, we're getting a lot of fake YouTube messages to our email address. We see you, scammers. Stop it. You're being naughty. We're not going to fall for your tricks.
That's really rude of them. Hey, by the way, I forgot, this was like a really important thing I wanted to tell the audience. If you have an old butterfly IQ, if you are using one of the old wands, they will no longer, I think it's September or October, I can't remember. It's soon, okay? The end of 2025, I believe, you will not be able to use that wand at all. It will not work with their software of any kind. But the good news is, if you write them and you tell them, they will give you an exchange amount. And anyway, my wand is, gosh, I guess it's like 7 or 8 years old now. It's so beat up. Them giving me a trade-in value plus a brand new wand would be so great. So if you have an old butterfly IQ, please contact them directly and ensure that you get an updated device. The end.
Nice. Good PSA. Well, more information on the original advanced emergency medicine boot camps, the emergency medicine and acute care course, Incrementum, if you're into that, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
New and upcoming courses are going to be announced for 2026, believe it or not, so keep checking back for more of the advanced boot camp and the original boot camps.
Thank you for listening and attending this episode of The Two of You. You can subscribe and rate us. Please rate us. We've got a pretty respectful ratings on Spotify. Did you know you can rate people on Spotify? You can. We've got a lot of 5 stars. We'd love to read your 5-star review of our podcast on the air, so to speak. You can also get us on Google Podcasts, now YouTube Music, and Apple iTunes Podcast. Search for 2View Emergency. That's the number 2View Emergency, and it'll come right up. Ratings help us climb the charts so that other clinicians get some 2View goodness like you did today. If you like YouTube and you want to see Martha messing with her head, if you want to see my very nice plaid sweatshirt, my boy Goon has one that matches. It's actually a button down, but regardless, he does have one that matches. You can catch our video podcast, Center for Medical Education, on YouTube. Don't forget that website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett.
And our show notes are by you and me. Well, thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on the 2View. Have a good day and a great shift. I'm going to go put my finger in an orange.
Cutie? Couty? What did you say?
Quaddy.
Quaddy.